I've just got a couple of things just to say before we start off. I just want to say in relation to questions from members of the public, the CCG is committed to openness and transparency and therefore wishes to conduct as much of its business as possible in a session that the public can attend and observe. This means that although the meeting is held in public, it is not a public meeting. This means that there is no opportunity for the public to ask questions apart from that offered at the Chair's discretion, and there is a specific slot at the end of the agenda for items not pertaining to the agenda itself. The governing body meeting is also being video recorded as part of the commitment to make information as accessible as possible. The video will be put onto the website within a few days of the meeting. The CCG does not allow any other recording of the governing body unless agreed by the Chair prior to the meeting. The CCG has a protocol setting out how it will conduct its meetings, and this is available on the website. So, saying that, welcome everyone. I've got apologies from Dr. Phil Moore, and I think Pete Smith is not very well today, so he's not going to be attending either.
Annette is on holiday, and Yarlene is.
Okay, and we've got apologies from Annette Peltz, our governing body GP member, and Yarlene Roberts, our Director of Finance. So if we can just make sure that our mobiles are switched off or switched to silent, I'd really appreciate that. And what we can do, just have a quick introduction around the board so that members of the public are aware of who is attending. So my name's Naz Giovanni, I'm GP in New Malden and also chair of this governing body.
Sarah Blow, Accountable Officer.
James Murray, Chief Financial Officer.
Jim Smiley, lay member.
Paul Gallagher, lay member.
David Knowles, lay member.
Catherine McDermott, Local Director, Primary Care and Planning.
Nadeem Naeem, Secondary Care Specialist.
Liz Muribo, Health Watch Kingston.
Naeem Iqbal, GP Board Member.
Gareth Hull, GP Board Member.
Catherine Yates, Nurse Member.
Fergus Keegan, Director of Quality.
Vicky Harvey-Piper, Local Director of Corporate Affairs and Governance.
Julia Travers, Director of Commissioning.
Atin Gold, GP and Chair of the Council of Members.
Jo Dandridge, Governance and Business Lead.
Tonya Michaelides, Managing Director.
Okay, thank you. So if we can come to the minutes of the last meeting held in July, as regards matters of accuracy, can we just come to page 1, page 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. Okay, so if we can sign these off as an accurate record. There are no outstanding actions from the previous meeting. So if we can just come to the opportunity for members of the public. Sorry, yes.
Sorry, Chair, if I could just ask, there was an action item, as I understood it, which is on page 8, and it's item 18/74 under effective commissioning, and it looks like an action point. It's on the reasons for declining certain procedures and the usefulness of having some information on that. And I think it may well have been me who raised that point previously, because if we have that kind of information at Health Watch, then if somebody raises a query with us, we have the information to hand, you know, to be able to answer the point that they're making.
Okay, so we've got the information, so we can forward it directly to you. It is actually as a South West London ECI document. So it's quite a hefty document, but it will give you some guidance as to the procedures that we're looking at. Sarah?
I think we've actually got it on website, so I think we can probably send you a link rather than, because I think it's available to the public. So if we can send the link out, and within that there is the policy, and then there's a whole load of documentation around the evidence base for the decisions. So you might want to pick carefully which bit you look at, because there's quite a detailed explanation of every single one of the areas.
Thank you. So if we can come to items on the agenda, and if there are any questions from the members of the public that we may be able to pick up on the agenda itself. No? So, okay. So if we can go forward with the Chair's report. So I'm just going to give a very brief verbal report. I'm going to split it into two, which is South West London and National, and the second bit is around the local. So South West London and National, just to let you know that I've been asked to be the board member, the London representative board member for the NHS clinical commissioners. So that role started in July. So that's a way of being able to feed back up nationally as to our concerns from a local perspective and also from a London region's perspective. I'm also, as part of the South West London STP clinical lead, working alongside Sarah with the other 4 AOs, accountable officers, and with the other STP clinical leads, along with the London chair of chairs, to look at moving forward the effectiveness around clinical strategy, and also looking at clinical input into decision making as well. So that's going on South West London national level. Local level, there are 4 things I just want to just give you an oversight of. One was around the outpatient redesign programme. That's still progressing at pace, and we should be slowly starting to implement that towards the end of the year. The ECI guidelines that we've just mentioned before, we're actually refreshing this at present according to there's some national work which has been going on, and we're starting to provide feedback into the national work. Around the musculoskeletal processes, we've got a first contact practitioner pilot starting probably in the next couple of months, along with this single point of triage, and they're going to be working quite closely together. And along with that is the capability framework, which has been produced at a national level. So there are things progressing around the MSK work. And lastly, but quite important, I thought I'd raise it, that Kingston Hospital NHS Trust has actually had a very good CQC report, which has been stated as outstanding. So I'd like to congratulate the staff and the people who managed to make that happen. So that's my very brief report. So I think that there was the accountable officers report.
I have nothing to add. I was going to mention Kingston. So
okay,
congratulations. No, congratulations Kingston as well, I think, from everyone. I think they're the only trust in London to have achieved an outstanding at CQC. So I think that's a great achievement by them.
Few things just to bring to the members' attention this time. NHS England annually publishes an assessment of CCG performance, and for 2017-18 I'm very pleased to report that Kingston CCG obtained an overall good rating against the assessment framework. There are around about 50 indicators that we've measured again. So overall, our rating was green. We were amber on finance, and that is despite the CCG's achievement of financial balance and exceeding our financial control total. And that's because the assessment rating is based on the achievement of the CCG's quality, innovation, productivity and prevention targets, or QIP. And we had at one point reported an achievement less than 90% of the QIP target. So that's why we have the amber rating was awarded there. So we will work very hard in 18-19 to ensure that we get a green in finance, but overall our rating was green, so that's a really good outcome. An equally good outcome is that we also get throughout the year, we get assessment ratings published for some of our service areas, and we recently, the assessment ratings for 2 service areas were recently published. That was cancer and maternity, and I'm pleased to say that Kingston CCG received a rating of outstanding for both cancer and maternity, which again is fantastic and sort of reflects the CQC rating that Kingston Hospital recently received. So really good news for the quality of services that we're commissioning and providing for our population. Moving on, just to confirm that a position statement around over-the-counter medicines has been agreed for South West London CCGs, and that focuses on the conditions for which over-the-counter items should not be routinely prescribed in primary care. And this position statement is in line with NHS England's guidance, which was published in March 2018. And members will recall that we ran a local Choosing Wisely engagement exercise last year, and the national guidance covers items which we identified locally, but with some additional items. So moving on, we are supporting the Ask About Asthma campaign that has been launched this September through the Healthy London Partnership. And the Ask About Asthma campaign has been launched to coincide with the start of the new school year and to reflect the highest hospital admission rates for asthma are in London in children. So one of the highest reasons for admissions in London for children is asthma. So Healthy London Partnership and NHSE London are running a public awareness campaign to encourage small steps to improve the quality of life for children and young people living with asthma in London. As I say, Kingston CCG is supporting this campaign. Healthy London Partnership, I just mentioned them, they publish a regular update of their activities, and their latest report has been for July, and you can review it online. Just to say, the items covered in their update has been their award, Health Service Journal Award for Patient Safety, for our handover process for voluntary mental health patients, London becoming signatory to the International HIV Fast Track Cities Initiative, and an update on childhood obesity. Also published recently has been the Health Innovation Network's annual review, and this has been shared with partners, and the report provides examples of the work they have done across 3 core goals, which are to improve lives, save money and drive economic growth. Again, link provided for members to read the review if they wish. Just going on to a contractual issue, 111 re-procurement. 111 in South West London is provided by Vocare as part of integrated urgent care service, and performance by Vocare, the current provider, has over a significant period of time fallen below the level of expectations from commissioners. 2 contract performance notices have been issued relating to the service, with the most recent resulting in a recovery action plan being put in place in May 2018. Vocare are currently in breach of this plan and have been issued with an exception notice. This, together with the fact that the service specification for integrated urgent care service has changed since the implementation of the Vocare contract, has meant a decision has been made across the South West London CCGs that we would go out to re-procuring the contracts for a start date of September 2019, which is would rather than extend the existing contract. So the existing contract would come to an end in September 2019 with a further option to extend for another 2 years. A decision has been taken not to extend the contract to go out to re-procurement. And that sits with Sutton CCG as the host for South West London. And then finally, a reminder that our AGM, our annual general meeting, is here next week, isn't it? Yes. Tuesday, and it's in this room. So all welcome from 12:30. It's great to see as many people as possible. That's all I have to say this month, but happy to take any questions.
Okay. Any questions for Tonya on the Managing Director's report? No? Okay, so if we come to an update on the South West London STP, please, Sarah.
Yeah, so we did agree that we would bring a regular update to every governing body about the work that's going on across South West London. So this is an update which we are going to be sending to all of the organisations that form the Health and Care Partnership across South West London. And we're happy to receive feedback about how this is written and whether there's more information that you require or anything. And we'll try to, as part of this, incorporate some deep dives, which we've talked about before. But a couple of bits of news that come through from this information is that we have appointed a new independent chair for the partnership. Her name is Cheryl Coppell, OBE, and she has a huge amount of experience of working as a local authority chief exec. She's worked around accountable care organisations in Barking, Havering and Redbridge area, and she's also a non-executive on an acute trust. So she's got a lot of experience of working with the NHS and with local authorities. And Cheryl will start end of next week formally as our new independent chair, and Dr. Andy Mitchell will leave us, and we wish Andy well, and he's been fantastic at supporting us in an interim in this role. We've also got some changes to the quartet. As Naz said, Naz represents the chairs, the clinical chairs on the quartet, the four of us that support the leadership of the STP and the Health and Care Partnership. And we have a representative from local authorities, which is Jed Curran, who's the Chief Executive at Merton Council, Naz, myself, and a provider Chief Exec. And John Goulston, who is the Croydon University Hospital Trust Chief Exec, is retiring at the end of September and was our lead. And Anne Radmore, who you will know from Kingston Hospital, will take over as the lead on behalf of the providers. And that's all providers, not just acute providers, but community, mental health, every NHS provider in South West London. So we welcome Anne into that role, and we wish John well with his retirement. And there's some information in here about some of the big work streams that we're doing across South West London, such as workforce and estates, and information on things like our cancer work stream, urgent care, primary care, which you can find in here. You will recognise a lot of the work that's going on. You'll also see that the local transformation boards have put in a brief update of where they are, and you will be receiving separate information in Kingston about the Kingston Health and Care Plan, which will be a focus in Kingston around how we deliver services locally. And that will feed into the work that we do at a South West London level. And I wasn't really going to say very much more than that, but I'm happy to take questions. Oh, one area actually I did want to highlight is you'll be aware that there's been a green paper on children and young people mental health, and that we've prioritised children and young people mental health across South West London as an area that we would like to work on, and in particular have done a lot of work around self-harm. We've been invited to apply for funding through wave 1 of the new Green Paper process for 3 boroughs in South West London, not including Kingston at this point. It's at Merton, Sutton and Wandsworth, and that had to do with some criteria that were set nationally. However, we will be putting in a bid that says clearly that this is a priority for us in South West London, that although those 3 boroughs we would see as maybe going first wave, that we would want to quickly roll any learning out across the other 3 boroughs in South West London, and that if there's anything that we can do prior to maybe Kingston, Richmond and Croydon going wave 2, we will try and do that across South West London. So that's just a brief update on that, because I know that's of great interest to people locally.
Great, thank you, Sarah. Any questions around the STP update? No? Okay, thank you. Right, so if we can come to the paper on South West London commissioning intentions for 1920. Julia?
Thank you, Chair. I'm going to present to the board this afternoon the draft commissioning intentions that have been produced for South West London and the individual CCGs that are part of South West London, which will be the commissioning intentions that we will use to advise local commissioners, local providers of changes that we are looking at making in terms of our commissioning of local services. These are brought in draft, and I very much welcome comments from members of the board about their content, but I'm aware that many of you will have been involved as clinical leads in the work across South West London and in the work that we're doing within the CCG. These commissioning intentions are produced as part of the commissioning cycle, whereby at the end of September we need to be giving notice to local providers of our intended changes in terms of commissioning direction and strategy. And they have been produced in 2 parts. There's parts, 2 sections. Sections 2 to 11 cover the South West London areas and cover the whole range of patient and disease groups such as cancer, maternity, integrated care, mental health. And by working together across the South West London, we can actually together work to deliver better outcomes for local patients, but also look at how our investment in priority areas can actually deliver greater efficiencies and effectiveness and some savings for the local system. These are set off draft at this moment in time, and I'm going to assume that you've read them. They will, of course, be further refined once we receive the 10-year plan, which is pending, and also when we receive the NHS planning guidance, usually on Christmas Eve, which will also give us the direction of travel in terms of key targets, other priorities, and also the financial environment in which we will be planning. I believe that the commissioning priorities and intentions as shown do very much also reflect the discussions and we've had with local people as reflected through the Health Watch report and through the annual PPE engagement. And those themes show how actually the comments, the feedback on local services through that engagement are actually featuring and flowing into and informing our commissioning intentions. And also they will flow into the local health and care plan, which is under development. As I said, I'm assuming that you've read them, so I'm not going to go through them in detail, but very much welcome any comments, feedback, any gaps that members of the board have on the commissioning intentions. Thank you.
Great. Thank you. Jim.
I think these are really good. I've got a couple of points linked. One is that you can be forgiven for reading through them for thinking that the patient is slightly forgotten. This is all about kind of systems and institutions and money. I think patient experience ought to be brought out more vividly as to what is this going to do, how is this going to improve the patient journey and the patient experience of the system. And as I've said that, we had a conversation in Kingston last week that several of us were at around looking at opportunities for transformational change, and we were focusing particularly on primary care, and perhaps we could reflect some of that conversation in the primary care section here, particularly when we talked about kind of the patient experience in terms of using primary care at scale to enable the patient to get to the right person first time, as opposed to going around the system a little bit first, which would be both more effective and a better use of the at-scale opportunities we have. So, just as an example.
Okay, any other comments or questions? Gareth?
Thanks, Juliet. Just a very comprehensive document. Just a couple of points I just wanted to mention. One, I wonder whether it's worth talking on the primary care, particularly primary care at scale, whether we can mention something about using the advantages of working at scale, but also making sure we don't lose the continuity and the local knowledge that that may be lost working in a larger organisation, and making sure that we don't lose that, because I think patients really do value that. And then secondary, looking at the cancer in section 4, I think there's a lot of intentions to bring a lot of work out into primary care, access to scans, access to tests, and I suppose we just need to be wary that the funding, the training, the educational component for the GPs who are accessing those tests and investigations sort of follows the work and goes with it.
Thank you. Liz?
Yes, I was interested on page 13 to the reference on children and well-being practitioners, and I'd be pleased to, if we could send us some information on who these people are and their professional formation, the age group that they will be working with, and so on, because it seems to be a new role and a very interesting one.
Okay, Julia.
That links part to the, as I understand it, the Trailblazer application that we've put in for 3 of the CCGs within South West London, but we do have in Richmond, we have had children and wellbeing practitioners working into our schools, and it's been up to local schools to opt to use those services. But Liz, I can certainly find more information about them as a role and what they do to contribute and work to support children, young people, as well as teachers in supporting and promoting positive health and well-being.
Okay, Catherine.
Thank you very much, Chair. I think it's a really comprehensive and really clear commissioning intentions document. So thank you very much for all the work that's gone into that. And I do recognise the commissioning intentions that I've described for Kingston, although I do take on board the comments around primary care at scale. I wonder, however, given as this is a high-level document, we might better be focused on refreshing the Kingston primary care strategy to reflect what primary care at scale actually means in Kingston and what it could be used to deliver and the investment that's needed, because I think that would be the document that you'd have more of that granular detail within that, and therefore in this commissioning intentions document you'd include a line saying refresh and delivery of Kingston primary care strategy. We also had the benefit of a conversation on this morning, and I understand that there will be a separate document that sits beside this that describes the enablers, and I'm thinking about the technology and the digital and all those opportunities that allows us to build on to be able to deliver the commissioning intentions. But as I say, so I think it's a really clear and helpful document. Thank you.
That's great, thank you. Any other comments or questions from board members? Catherine.
I was just going to go back to number 13 around developing...
You just put on your...
Oh, it's on. I was just going to go back to the point around page 13 around developing the workforce and the wellbeing practitioners. Because it says school links, but it's just ensuring that the borough is obviously has a large amount of independent schools, and it's about making sure that are we clear that that goes across both state and independent where appropriate.
Thank you. Any other comments or questions? It's a really good document. So I think you need the final comments back by when?
Could I have them back by the 14th of September? That then enables us to turn the document around and issue out formally to providers on the 30th of September. So any further iterations, comments and feedback would be most gratefully received. Thank you.
Again, I'm presuming the outpatient redesign process is actually embedded in the document
it is,
as well?
Yes, it's reflected in both our CCGs across the LDU, yes.
Great, thanks. Rob.
No. And would that be at Kingston or Epsom and St Helier?
Well, he does it at Kingston and at St George's as well.
I suppose it depends on what surgical procedures he does. There are a range of ENT consultants, some who will do non-surgical management and those that will do surgical management. And within that, they will have specialisation. So it depends what is the problem of the individual patient, but there's a whole range of ENT consultants and clinics that are available.
That must have been coincidence, because I've spoken about 4 or 5 people and they're all had to wait because they're all being done by Mr. Obo. But it must have been coincidence.
There are a variety of ENT surgeons. Okay, thank you. Right, any other comments or questions around the draft document? That's great. Julia, thank you very much. And if we can just make sure that we do feedback up until the 14th of September, because it has to be put out by the 9th of October, submitted. Okay, thank you. So if we can come to Kingston Health Watch annual report. Stephen, sorry. Hi. Okay. Stephen, do you want to come and just take a seat? Thank you. And just introduce yourself, thanks.
Excellent, thank you. I sat here last time and I was pretending to be Liz Mirabeau. Now I'm Iona Liddington. Thank you for inviting us to present highlights, and I emphasise the term highlights. You'll have obviously had sight of the report that's been published on our website since the end of June, and they were distributed as part of your pack. So I'm not going to sort of do a page-by-page flip through this, reverting for an option for questions at the end of my kind of highlight trip through this, if that's all right. Just to point out that many of you will know already, but for the record, Graham Snelling is stepping down, or has stepped now, as chair of Health Watch after 5 years at the end of August, and Liz Mirabeau has taken up that mantle. So welcome to Liz from our perspective. The report itself, as my message says, it covers about 7 months' worth of work, really. Obviously, there was work going on, ticking over prior to the new Health Watch Kingston team was in place from around about August last year. So we've tried to capture some of the kind of key deliverables that we got up to across that period. These included contributing, of course, to the ongoing work around and scrutiny of the Thrive Kingston mental health and wellbeing strategy, challenging the lack of specialist personality disorder care for Kingston residents, improving the Kingston ICOPE service by using service user feedback and experience to influence commissioning design and delivery, examining the suitability, I suppose, efficacy and cost effectiveness of new and planned services that mean people will only have to go to hospital when they need to be there, which I'm sure is quite central to a lot of the discussions at CCG. Community engagement of the future, or on the future of home care provision in Kingston linked to Kingston Coordinated Care, and we are just still waiting to issue a planned survey to patients from Kingston Hospital being discharged from Kingston Hospital on the experience of their discharge, particularly focusing around the communications that are in place around that particular process and people's experiences of the information that's shared with them, how clear they are, for example, whether they feel comfortable with the information provided, understand everything. And of course, we have ongoing complaints. Oh, I'm in Iona's chair now. Apologies, Iona. Moving on then, of course, you're all familiar with the work that Health Watch will be in place locally to deliver. That's we're sort of here to sort of scrutinise locally through residents the sort of health and social care service delivery across Kingston. One particular piece of work that we are just finalising was our recent visit to Tolworth Hospital, where we were reviewing we did an interim view of the community mental health services in Tolworth Hospital. That report is imminent to be published. We're just waiting to hear back some further clarification from the hospital staff. So more on that later. Skipping through here because I want to get to, there we are, page 16 of your papers, where we highlight the top 5 work areas for 2018-19 that we've identified. And key to the work of Health Watch Kingston, of course, is the fact that we support local residents to meet and discuss and decide for themselves what their local priorities for us need to be for the coming year. And you may or may not be familiar with the fact that we have 3 established task groups. These task groups are supported by a range of volunteers called our active affiliates, and they work in 3 areas: 1 mental health, 1 learning disability, 1 hospital services. We've added, sorry, my apologies, 1 mental health, 1 hospital services, 1 community services. We've added to that recently an area of work in and around our accessibility to people living with a learning disability, and also worked with young people across Kingston and Richmond to create what is now called Youth Out Loud, which is the young person's version of one of our task groups. So Youth Out Loud is supported by both Health Watch Kingston and Health Watch Richmond, and we will mirror the engagement and support across the 2 boroughs for young people. We're particularly working with the Kingston Richmond Youth Council, but we're very keen that we take the engagement beyond just the council and engage youth clubs and schools and so on. So that's fledgling, emergent. We're nurturing that at the moment and developing skills and providing training opportunities. There's a series of films which we're sort of planning to make with young people. So they're by and for really young people, but we're providing the kind of training and the opportunity and the tech facilities, I suppose, to sort of create those. But they are going to be a series of films that will come together as a set of 6 films. Some have already started in Richmond. We're going to be adding to those from Kingston. But it will create a library of 6 short films on the health and well-being for young people, the particular issues led by them, about the services that they access and information that they feel is appropriate to share. I'm going to leave it there if there's any questions. Chair. Thank you.
That's great. Thank you very much, Stephen. Any comments or questions from board members? I've just got just a couple of queries. I presume the Youth Council, you mean the Youth Parliament in Kingston, or is that something different?
Yes, we're engaging all those parties. Am I on or off?
And just based on your top 5 work areas, do you have areas that are actually looking into primary care as well? So linking in with the PPGs?
Of course, the work that we do within the community care services tends to sort of reach into primary care, because people obviously access primary care through that particular area of work. But I think, you know, primary care tends to sort of come, you know, permeate through all of the work streams, really. We don't have a specific primary care task group, but we're very much involved with listening to and trying to sort of promote the views of people living locally around their primary care usage.
Thank you very much. Any other comments or questions? Fergus?
So firstly, just wanted to acknowledge Graham Snelling's contribution to the Kingston Safeguarding Adults Board. He's been a key partner for some time, and delighted to see that he's going to continue in that element of a role for the coming 12 months. I guess the element within that is the desire from the Safeguarding Adults Board to develop a community reference group. That has been a challenge for the Kingston Safeguarding Adults Board for some time, and hoping that we're able to see some progress on that in the coming 12 months.
Could I just reply to that one, Chair?
Thanks a lot, Fergus. Yes, Liz.
Yes, the CRG proposal should be imminently going to the chair of the Adult Safeguarding Board, because certainly we've discussed the content with Graham, so it is on its way. And I think the other point in relation to primary care is that 2 of the trustees go to the primary care forum that is run by Hannah Keats and currently her successor. So I think at the moment we're picking up quite a lot of our primary care information through that route, plus of course I sit on the primary care quality and development group. So at the moment I think we feel we're getting quite a lot of information through those routes.
Really helpful, Liz. Thank you. Any other comments or questions around the annual report?
Could I come back in just a moment? There is one further point, of course, to make on primary care. That's the work we're planning on the discharge project, because it's very much about discharge into the community and actually sort of what patients then experience with regards to their primary care. There's been some further discussion recently about the types of information that's shared between hospital services and primary care. For example, if somebody's in for a hip replacement and they're diagnosed or assessed within hospital prior to discharge, that they may be sort of early stages dementia, then what happens to that sort of patient, and what sort of feedback between the 2 sort of areas of care are provided.
That's very helpful. Thank you. Any other comments or questions? Okay, so if we can come to the next item on the agenda, which is attachment F, which is the patient and public engagement review. Vicky, are you taking this? Oh, Jim. Okay, thank you.
No, Vicky's going to do the real work. I'm just going to make a couple of introductory comments. As the board sponsor for this, I just wanted to say a couple of things by way of introduction. Firstly, just to point out the obvious, which is that this is a very challenging time to engage the public on the NHS. There's a huge amount of change, both in prospect and in practice, in acute and primary care particularly. But it makes it even more important that we continue to talk, that people do understand exactly what's happening to the care services which we are commissioning and delivering for them. Secondly, just to point out the sheer scale of the work that was been conducted over the last year and was represented in this report, it kind of goes from kind of small group conversations, visiting clubs and groups from all sections of the community in the evenings, telephone and face-to-face surveys, street stalls, drop-in sessions, markets. The team has used as many channels as they possibly can to get the widest possible engagement, and I think they should be applauded for that. And then just to illustrate the work through 2 bits of it, which I perhaps know better than some of the others. One is choosing wisely, which has already been mentioned this afternoon. Choosing wisely, I thought, was an example of a new kind of engagement with the public, because that was engaging people over some very difficult choices that we were making locally and within South West London, and the NHS is making nationally. And I think it was extraordinary how grown up those conversations were about difficult choices in terms of prescribing and in terms of access to services. And I think that boded well for future engagement. And finally, the quality in primary care work, which was a significant piece of work with 1,100 people engaged in telephone surveys to talk about the best kind of model of primary care, the kind of contract we want going forward. And that was a very important piece of work as we continue to develop the local KMS local contract with general practice and to look at moving into primary care at scale. We have a very good idea, both from primary care practitioners and from public and patients, of the kind of services which work best for them. Over to Vicky to do the real work.
I can't really take any credit for the work because we have a very good engagement team, and reflecting on all this work, I feel that we've really benefited from joining up our resource with Richmond, and we've got a much stronger team, and we've also learnt a lot of lessons from the two CCGs in terms of good engagement practice, and I think some of that is reflected in the report. We no longer are mandated to produce a report, but we just felt very strongly that it was still good practice to do so, and hopefully it provides you with a really good list of all the good work that's been done. We were rated as being good for PPE by NHS England, but we do have an ambition to push forwards, and we would like to reach outstanding, maybe not next year, but the year after, but we really want to, push ourselves. In terms of what we need from the governing body is we just really would like you to think about what help can we give you in terms of PPE to continue to provide challenge around how we engage patients and the public, and also helping us to promote opportunities for people to be involved in our work. So it's not just about the people who do engagement activity, it's not just their business. We want everyone to have a relatively good understanding of how people can get involved, and obviously happy to support you to do that. And we would also like you to consider whether you'd like some kind of focused workshop around PPE to sort of get under the skin of it, if the business agenda allows. Finally, I'd just like to finish by saying that one of the big pieces of work that we'll be focusing on next is the engagement around developing the health and care plan, which, as you heard earlier, that work will really start to happen in September, and the reports will be published in March. There's quite a significant amount of work to happen with that. We have a very good communications engagement network working across both Kingston and Richmond, which is leading that work, as well as the wider involvement of the LTB members. But that's going to be a big focus for the next 6 months. Happy to take any questions.
Okay, thank you so much, Vicky, and thanks, Jim. Any questions from board members on the PPE work? Yes, Catherine.
I'd firstly like to thank Vicky and her team for the support that the comms and engagement people gave to the Quality in Primary Care programme of work. As Jim said, it was an extensive piece of work, and it was excellently carried out. I'd also like to update the governing body on the progress around the quality. We made a commitment, and it's highlighted in the PPE annual report, that we would have some quality pledges in place. We've established a task and finish group in Kingston that's chaired by Pete Smith that's taking forward that work. So we haven't finished yet. We're still taking that forward. And in terms of your question, would the governing body be interested in a workshop around patient public engagement? I'd like to suggest that we say yes. I have the privilege of being able to attend the Richmond Patient Participation Group Network, which meets on a monthly basis. And it's clear to me that Richmond has a much more structured approach to patient participation groups at practice level, which we don't really have here in Kingston. And the quality of the conversation and feedback you can get from a network of patient participation groups cannot be underestimated. So in Kingston, we've established a primary care patient forum, which is great, but it's not quite the same as every practice having a patient participation group where you can hear the comments from your own patients. Some practices Kingston do have, but we don't have comprehensive coverage. And I'd be really quite interested in thinking about how we can take that forward in Kingston. But just a big thank you to your team for all the help on that. Thank you.
Jim.
Sorry, I was just going to say, I meant to make one more point. One is about partnership, which is clearly part of this, and as Catherine's just reminded us, I mean, our partnerships are not perfect, but clearly this is work which is built on partnerships, and we ought to pay tribute, particularly as they're in the room, we've just been talking about them, to Health Watch Kingston, who we work very closely with, and the work on mental health, I think, was exemplary. And we should also take the opportunity to say thanks to Hannah Keats, who's been leading this work for the last couple of years and who's gone on to maternity leave. She's done some fantastic work for us, and we should wish her well officially, I think, as a governing body.
Thank you. I echo those thoughts as well for Hannah's work on this. Any other comments or questions from what? Sorry, Iona.
Hello, apologies. Iona Liddington, Director of Public Health, Kingston Council. Just to say, again, welcoming a lot of joint work that's been happening throughout the year. Good to see that. And I think as a council, we're looking to how we can engage with our communities more. And I think it's important that we do that across the whole health and care economy as well. So if we're going out for particular things, if we can include the health element and vice versa, we've got a health event including sort of some of the wider community elements, then I look forward to that kind of going forward too. But yes, I think an excellent report.
That's great. That's what I had down on my list, was that we just need to make sure that we're learning from each other as well, and that we're actually having joint up engagement programmes as well across the borough. So any other comments or questions from board members? Anything from the public? No? I would like to second what Catherine said around the workshop. I think it'll be a really good opportunity to try and pull this together a bit more and actually look at particularly around primary care as well. Okay, so if we can put that on the agenda at some point. Thank you. All right, so if we can come to the Safeguarding Adults Annual Report. Peter.
Thank you. Good afternoon, everybody. My name is Peter Warburton. I'm the lead for Adult Safeguarding at Kingston CCG. Safeguarding goes through all of our work, and it goes through everything that we do. So I've done the annual report, which covers quite a lot. Doesn't cover everything that we've been doing over the last year. So what I'd like to do is just summarise, because there's quite a lot to go through. So if I'm going to just look at 5 points. The first one that I'd like to look at is the prevent agenda. So we put on a trainer-trainer event in conjunction with Kingston Hospital in January, and that was for all hospital staff and for all GPs across the borough. We had great attendance from Kingston GPs and from Kingston Hospital staff, despite the fact that there was lots of winter pressures going on at the time. So the trainer event is to train people to know what to do and how to recognise if somebody's been drawn into terrorism or terrorism activities. On top of that, what we're also doing is we're going to do further training to look at if anybody is actually caught up in an event, what they should do. We're going to first of all work with the CCG staff with that presentation, and then we're going to move on to our GP colleagues at the GP Half Ed Day, and then we'll be moving that out into the community, because I think that's really important considering that the level is still high nationally, the threat of terrorism. So that's with the prevent work. I wanted to move on to the Safeguard Adults Board work that we do. That's on page 12. We've had 100% attendance at the boards, and as part of our work, we chair the communication subgroup. And part of the strategy of the communication subgroup is to get the message of adult safeguarding out to the community. And from our stats and data last year, we can see, and it's still the same this year, that the most vulnerable group are older women of, I think it's around 65 plus. They are the highest, one of the highest, or the highest risk group. So what we wanted to do is target those people to get the message across. So we've worked with Stay Well. I think we've done 5 sessions so far now with the Stay Well group to educate people about what is adult safeguarding, what you can do to recognise it, how you can get support, and if you feel that you are being abused. And we work with the Mental Health Carers Group. We've done a presentation with the Mental Health Carers Group. And we also did the Golden Years community group that was held here at the King Charles Centre. I think there was around about 100 people, and that was in August. And that was a really great event to come along to as well. So that's the work that we're doing with the board around community engagement. Also, as part of the board, we have a thing called Safeguarding Adults Review. So that's when somebody's been seriously harmed as a result of adult safeguarding or care issues, or that person has passed away because of care issues. Now, so far in Kingston, when the report was done, we have 3 Safeguarding Adult Reviews. 2 of those have now been completed. They're going to the board in October, and they will be published, and 1 is being undertaken as we speak. So that's the Safeguarding Adult Reviews. And I wanted to move on to page 16, which is about the Learning Disability Mortality Review, or LEDA for short. It's a national programme looking into the deaths of people with a learning disability, and the whole aim of that is to scrutinise any care activity for somebody with a learning disability who has died. So basically seeing if everything was done that wasn't prejudicing that person because they had a learning disability. So in Kingston, we've had so far 4 completed reviews, and we've got 1 review to be undertaken. Out of those 4 reviews, 3 reviews, there were no major issues to note. 1 of those reviews, we had a multi-agency review, and there is some learning, but also we found that there's examples of good work, especially around the care that the person received in Kingston Hospital. Also, as part of the Learning Disability Mortality Review, we received a little bit of money from NHS England, and that was to support us with our reviews. Because we were ahead of our reviews, we were able to use that money to produce a short film in conjunction with NHS England and MenCap. And the film is aimed at GPs and practice staff to look at what is the mortality review about, how to support them with a mortality review, and also how to, the importance of annual health checks for people with a learning disability, because we find that annual health checks nationally for people with a learning disability aren't being undertaken as they should do, and that's really, really important. It's having a negative impact in a way. So we produced a film. It's gone out nationally. We've had good reviews and good feedback from that, both from GPs and colleagues in other safeguarding CCGs across the country. So that's that. Page 19, we also received last year we put in a bid for training, bespoke training for GPs across Kingston and Richmond, and we were successful in the bid. So we've run a course over 2 parts in July, and the second part is to be completed in September, and that's for our GPs looking at Mental Capacity Act and Deprivation of Liberty Safeguards trainings, but quite in detail. And then the last part is the data collection. So if you look at page 21, we've just got some of the feedback on the charts from the borough statistics of when safeguarding referrals and enquiries are received. But also what we've done across the CCGs in South West London is we found that our data has not always been consistent. So we've worked with all our provider services now to come up with a standardised document for safeguarding reporting every quarter, which we can use for our annual reports, they can use for their annual reports. But if you just want to check, I assume everybody's looked at the report, there is the same consistent message, I suppose, year on year, that older people are the people more at risk of safeguarding issues, and out of those people, it's usually older females. If we look at the places the types of abuse, the main type of abuse is neglect, and that can be all sorts of issues. and in all sorts of areas. And the main areas that we're looking at where the inquiries by location, in the person's own home, second in the care home, supported living and hospital and other. And I think that's all the charts. If anybody's got any questions, I'll just run through things very quickly there.
Thank you. Fergus.
Thank you, Chair. I think this is an important report. There's a lot of detail in there, and there have been a lot of changes in the obligations and requirements of CCGs in terms of compliance with the various statutory instruments that are important to us. So I think it is a very detailed report, but I think probably what's not necessarily come across is certainly how fortunate I think we feel as a CCG to have Peter's leadership of our safeguarding agenda. His reputation, both locally and at the NHS England level, is really appreciated, and particularly for his focus on the learning disability mortality review. And Peter now coordinates that with leads from across South West London to make sure that operationally these programmes of work are taken very seriously and taken forward very quickly. And also the benefits of the local delivery unit ways of working. So with his opposite number, Sarah Loads, on the Richmond side, what we've got across Kingston and Richmond is some resilience between the two CCGs for the safeguarding agenda, which I think I'd like to just, on behalf of the governing body, acknowledge the great work that he does and to thank him for his report.
Thank you.
Yes, thank you, Peter. Right, any other comments or questions around adult safeguarding report? Yes, right, no.
Peter, thanks for the report. It's very comprehensive as usual. I was just looking at the section on modern slavery. That seems to be getting a lot of attention nationally at the moment, and the number of reported instances is quite low in Kingston. I suspect part of that is because GPs and members of the public aren't very aware of what signs to look out for that. Is there going to be some form of training for professionals and the public?
So what we've been doing as part of the community engagement group, and that's working yet with especially with the groups that we've done already. We go through the different types of safeguarding issues, and modern slavery is on there, and we do. People always ask us, what does that mean? What is it all about? Because it is becoming more of a topic that people are understanding. So we have been working on that, and I think at the last, because it's not in this report, but at the last GP Half Ed Day, we did run, or I did a presentation on modern day slavery. We've actually just had an updated presentation, which I'll be using at our next training event. Thank you. Yeah.
That's great. Thank you. Thanks, Peter. Any other comments or questions from board members? So this is here to note. Happy to note. Yep. Okay. Any questions from public? Okay. All right. Thank you. So can we come to the social prescribing update? So Atin, I don't know whether you're introducing it, Catherine. Are you introducing?
Would you like to, or shall I start off, Atin? So within the governing body pack, you have an update on the social prescribing pilot that's currently located at Surbiton Health Centre. It's a joint venture that Kingston Public Health Team and the CCG put in to Macmillan, and we secured funding just over 104,000 for a 24-month pilot. As it's Macmillan, it's targeted patients who are living with or post-cancer. But the idea being that if you can find the social prescribing model that works, you can roll it out across all of the conditions if necessary. So what you have here is a report from Macmillan, which was their first interim report. The next one will be due in December. What we've learnt from this first report, so the 4 practices at Surbiton Health Centre, Langley, Berrylands, Central, and Brunswick and Canterbury are participating in the pilot as the initial stage. At the point of time of this evaluation, over 59 referrals have been made. It'll be over 60 now because there's a little bit of a time lag between the evaluation and the conversation today. Interestingly, there's a high number of people who have anxiety, mental health. So, I guess not unsurprisingly, if you're living with or post-cancer treatment, so that's not unsurprising. Possibly what is surprising is that over a third of the patients also had another long-term condition as well as cancer. So there are a multiplicity of things that are happening in these people's lives. The evaluator also interviews the carers of the people who are included in the service, and there's some really interesting feedback from the carers around signposting to information and ongoing support. And again, I think that's probably all wrapped up in the health and mental health and well-being sort of aspect of this service that's being offered. So the pilot's run for 6 months. It has another 18 months to run. What the next evaluation will include for you, the patients that have been identified and assessed and treated in the first 6 months will be tracked through our risk stratification tool. So we will be able to demonstrate if the intervention of the social prescribing pilot has had an impact on the number of interventions they have with either the mental health or acute or their GP. So we'll be able to get some real numbers that will demonstrate whether that particular type of social prescribing, because there's lots of different ways you can do it, has actually made a difference for those patients. The next tranche includes another 5 practices coming online with this social prescribing pilot. So we'll have doubled the number to 10 practices, which will be just short of half of the Kingston practices. You've got the Macmillan report as is. I've also attached for you an appendices that describes the methodology that both they want to achieve and how they're actually measuring the evaluation. So you've got a little bit more detail in the pack if you wanted that. So hopefully that gives you an overview. It seems to have had a very good start. Little bit of a tail off in numbers just recently, but that has now picked up again. And the feedback from the practice that are involved has been very constructive. And it has helped to identify patients that practices hadn't necessarily been aware of. So I'm going to stop there and let people ask any questions. I don't know if Atin wants to add anything or people just have a general conversation.
Thanks. Is there anything you want to add, Atin?
No, well, thanks, Catherine, for doing that. I wasn't a bit unprepared for that one. No, I look forward to it now expanding, and we hopefully get some more numbers and some good outputs from that over the next few months.
Can I just ask a couple of questions, if that's okay, Catherine? The first is that the number of referrals coming in from different practices of very similar sizes are very different. And is there any learning from one practice to another about the referral process itself? And the second is, you were talking about social prescribing on a much wider scale going beyond cancer. I know Croydon do an awful lot around the social prescribing, and they've got very good outcomes from it. So I don't know whether there's a bit of a learning across South West London that we need to do as well. Sarah.
So coming out of a discussion that the Chair's had, I've been asked to pull together an assessment of what we're doing across South West London on social prescribing as a whole and share that widely. So we will do that. We'll see what the best practice is in South West London, but I think we also need to look wider and see, because there's an awful lot of people doing social prescribing nationally. It's an area of growth, I think, and an area where there's some really good outcomes. So we'll try and pull that together and make sure that we share that widely.
Thank you. Naeem, then Iona.
Thanks for this report. I was just looking at the improvements in things like anxiety and depression scores and health scores, which seems to show quite a good picture. But actually, with these figures, there's no comparison. There's no control figures here. So it's really difficult to know whether social prescribing has made a difference here or whether things would have just changed anyway. It'd be useful to have some sort of control to compare the benefits.
I'm just coming back to that. I'm pretty sure there is evidence from elsewhere that it does, but I agree with you. These figures you can't do that, but there is evidence elsewhere. Sorry, Iona.
I think just to follow up for that, I'm not sure in terms of sort of a research programme, so we're trying to evaluate it, but clearly if we're going to go with a pilot group that we're not doing an intervention with, I would think we'd have to go to our research committee and all of our ethics committee, which was not the route that we went down in order to get this kind of up and going. So I appreciate it's a bit of a a weakness because you can't do that direct comparison, but I think it's more of a monitoring and evaluation tool. So just to come back on that. One of the challenges has been that the member of staff that's been doing the social prescribing has actually, we've had a gap, so she's finished, but we've now, again, picking up that point of trying to connect it with the wider social prescribing work that's going on, so our connected Kingston model. So it's actually one of the public health team that's now fulfilling this role half-time, and we're appointing to the other half. And I think that makes for a more resilient model as well. And they will be part of the wider sort of discussion group and peer support as we get more of the community connectors across Kingston. So whilst this is a cancer-specific project, the learning from this, given it's been our trailblazer in some respects, will be used across the connected Kingston piece as well.
Great, thank you. Jim.
I was also going to make the point about effectiveness, and clearly control is as Iona said, is a complicated ethical issue. But my point was, as people have already mentioned, that social prescribing is quite a buzz phrase at the moment, and there are a large number of different understandings. And I had to read these papers with some care to work out exactly what was being offered to the patients here. Can we make sure when we use, particularly when there's things which are in current use, when we start to describe them, we describe quite specifically what the patient is being offered, that they would not have been offered, what services, and can we start by doing that? So we start with an understanding of what this pilot is all about. You have to get quite a long way into this before you can work that out, or I did anyway.
It's just a quick question about the numbers of patients involved. So the pilot's going on for another 18 months, and we've got 5 practices at the minute, and then 4 or 5 more coming on. Is the thought to have all the practices involved in the pilot, or is there a limit as to how many that can be involved?
The intention had been that all interested practices would be able to participate in the pilot. And I think, and I hear what we say about social prescribing, and it's a buzzword, and there are actually lots and lots and lots of different models. So it is very important that we use this opportunity to learn from other examples of social prescribing. And I'd hope as a pilot we would be able to modify and update and amend it as necessary. I take your point about being really clear about what does social prescribing actually mean in this particular context. There is a helpful slide in the pack, but you are right, it's probably far too down, given that we have so many different examples. So I'll take that feedback back and make sure that our next report is much clearer on what the specific offer in this particular pilot is.
Okay, thank you. Any other comments around this? Catherine?
I was just going to point out, because obviously one of the 7 Macmillan Cancer Support outcomes is obviously around those around me are well supported. It's clearly identified that 18% have 1 or more children under the age of 18. What I'm not clear about here is what the offer is to them. What support are they being given to those, to those children and young people? And it'd just be really useful to have a bit of clarity around that.
Thank you. Any other comments from board members? No? Rob, you want to say? I think you are, yes.
So, yes, you can, and I believe the model that I've forgotten the lady's name, the first lady we had in place, she would literally be sitting, Grace, that was it, Grace. She was literally sitting in the waiting area of Surbiton Health Centre and trying to make as many connections as possible. So I imagine that's the model of working going forward, so it should be relatively easy to make contact.
It's only because I go to these meetings that I knew about this, that I told them about it. They need more communication, really.
Yeah. Yeah, maybe something we need to take forward with our patient public participations. Yeah. Okay. Thank you, Rob. So, any other comments before I wrap this up? Yes, sir. Can you just introduce yourself?
So my understanding from being involved early on is if we were going on a research methodology, we would have had to go through an ethics committee approval, which would have taken a lot longer to develop. So we were going for a pragmatic, getting something off the ground to make a difference, using the evidence base of what works with social prescribing, so particularly using things around the Sheffield and Rotherham models, also those used in Essex, in terms of using that evidence base for what we're applying here. So we could have gone for a research-based methodology, but we opted not to. I think it would be good to fund more research-based projects, but I think you'd have to have the budget for that and the timescale and run-in for that too. We're also looking at the evaluation of our connected Kingston model, talking to Kingston University. But again, the scale of the research will have to reflect the budget available.
Okay, thank you, Iona. All right, okay, so this is just for noting at this time, and we'll bring it back as regards the wider social prescribing piece as well at a later date. Okay, thank you. So if we can come to committees in common across Kingston and Richmond LDUs. James, do you want to kick it off? Thank you.
Sorry, so I'll take this area in two parts. So the first one is looking at the committees in common for the LDUs for finance and audit. We've got them up and running now, and it's really, as we've talked before, aimed at sort of getting a better sort of outcome from working together, sharing some of our experience and learning and making better use of our resources. So the purpose of bringing this to the governing body today is really just to ratify the terms of reference, but I'll just hand over to Paul and David whether they wanted to make any comments on how it's working.
No, I mean, from an audit perspective, we fully endorse this. It seems eminently sensible to try and bring both committees together. I guess it's helpful when I'm chair of both committees as well. It makes it slightly easier. In terms of making sure that we have the nuances for each committee, we're not going to lose that sort of local involvement. When there is a decision to be made for a separate committee, then that committee makes that decision. But otherwise, I think the view was we have the same internal auditors, we have the same external auditors, and therefore, the conversations and the process and the cycle throughout the year is the same. So, again, we fully endorse that at audit committee.
From the finance point of view, much of the same points apply from Paul. Effectively, it's a way of simply doing our business more efficiently. We will be more effective. We've some experience of it now, and it's quite clear that we can have the quality of discussions are marginally enhanced, in my view. But secondly, we're able to do it in more or less the same time that we did it previously, with the great advantage of working together with Richmond on this. It really isn't any loss in the autonomy of the individual CCGs. It is genuinely a way of making the decisions, making the commitments and having the conversations in a more effective way. So we've experienced it, it has worked well, and yes, finance is a little different because there are two of us. There's a finance chair from Richmond and I come from the Kingston perspective in that role. But we've made that work together without any difficulty at all. So I don't see any difficulty with this. It's certainly something I want to, I hope the CCG will approve.
Great. Any comments or questions around the finance, the recommendations around the finance and audit committees in common on the LDUs, Kingston, Richmond? Any other comments? No? So are we happy to ratify those two elements? Yeah? Agreed. Okay, thank you. Right, James?
And just to build on that, then we've had a number of discussions, as we've discussed at the governing body before, around having some operation together across South West London Alliance and also across wider South West London for audit and finance committees. And audit chairs have now received, audit committees have now received a paper which has been commented on and brought to this this governing body for approval in terms of how we can operate on an alternate basis, a committee in common across South West London, really to further build on the sort of advantages that we've outlined in the LDU discussion. And as I say, when you sit there with those meetings and you've got half a dozen very experienced finance and audit chairs, you've got quite a powerful a group there that I think we need to make maximum use of in terms of our committee structure. So audit committee, we will look to start from October, subject to approval, and we'll have a rotating chair on that one. And that is purely at the moment for the South West London Alliance, and we've invited Croydon to that one, and I think they will join, but that's how that's set up at the moment. In terms of the Finance Committee, that's slightly different, because clearly as we move forward, there are different expectations on CCGs and South West London about how we work together, how we manage system working, control totals, and also we have a number of areas such as procurements, and I think Tonya referred to one around one-on-one, where actually it would be beneficial for us to look at those sorts of things in one committee rather than across. So again, we're looking to move to a similar arrangement with that, but there are some nuances in that. First of all, Croydon will be part of that, because clearly they are part of our financial economy, as well as the South West London CCG alliances, and they're content with that. We will have an alternating chair, but it was felt by the finance chairs that ought to alternate every 12 months. So to keep some continuity with issues, it was felt that we'd have a single chair, and Bob Armitage from Richmond has volunteered to undertake that role for the first year. And the final part really was there was a strong, we've allowed for 2 members, as we have with the audit committee. Clearly one of those will be the chair. With the finance committees, it was felt that we needed to keep a strong clinical involvement, so we will be looking for GP representation around those. With both those committees, clearly we will want the chair, but it will then be up to each CCG to nominate their second representative. But clearly we can work through that with each individual CCG. Happy to take any questions.
Okay, Paul, do you want to add to this?
I would just add again, James. You know, I think we workshopped this back in, was it mid-May? Yeah. And I think all 5 audit chairs were in complete agreement that this was the right way to go forward. And, you know, same principles as we just discussed about Richmond and Kingston. I think the biggest initial challenge will actually be managing the meeting itself, having up to 20 people in the room. And we've seen the audit papers we produced for one meeting, then, you know, we don't want to multiply that by 5 or 6. So I'm not sure we'll get it absolutely perfect on the first meeting, but I think, you know, it's the right way to go, and we'll hopefully save on duplication of effort. So I'm fully behind it.
So before we come to the finance bit, if we can just stick with the audit bit, any comments or questions around Committees in Common South West London audit? So I've just got one point of clarity. I'm presuming this is to try and save duplication across the system around the audit committees. Is that right? Those are the advantages of this?
Yeah, absolutely. Yeah, okay. I think there is an attachment around the principles and the objectives, which, as I think James alluded to, I think it'll actually strengthen rather than dilute the capability there, but will certainly avoid a lot of duplication of effort. Okay.
So are we happy as a governing body to approve this? Yep. Okay, so approved. So as regards the Finance Committee in Common, David?
Little to add. It's I suspect this will be more complex than the audit one, and we will have to actually experience the proposed new arrangements, see how that works out. I was unable, I was on holiday a couple of weeks ago when the meeting was held, so I wasn't party to the detailed discussion. But I think that the note that has been circulated sets out some of the challenges which will be there, as well as the process. I think that's something which we'll have to review in the light of experience, but certainly I'm very supportive of the principle of this, and indeed our initial ideas as to how to make this work.
Okay, thank you. Any comments or questions for David or James? No? So as a governing body, executive, are we happy to approve this? Yeah.
Great.
Okay, approved.
Yeah, Chair, we should note in approving it that we need a conversation amongst ourselves about representation.
Yeah, okay.
On all the committees. Some are straightforward, one or two require a little bit more thought.
Agree, Jim, thank you. All right. Thanks.
And just to confirm that this has to go through all the governing bodies before we can move forward. So it's our week of governing bodies, so we will have completed that by the end of this week.
Yeah, that's fine. Okay, thank you. Okay, if we can come to attachment L, which is the board assurance framework. So, Vicky.
Thank you, Chair. You have an up-to-date risk register before you, plus the board assurance framework, which outlines the actions we're taking to mitigate our risks. We currently have 3 very high risks on the register. The first one is around the potential for failing to meet some of our national performance targets based on previous performance. The second is around potential overperformance in acute services and its ability to potentially affect our ability to meet our statutory financial obligations. And the third one is around failure to identify our required QIP savings for this year. So we've done some improvements around the risk register and board assurance framework. You'll remember that we agreed strategic overarching objectives for the organisation earlier in the year, and so all the risks sit under each of those objectives. And we've also outlined which committee oversees which risk, and we now produce detailed reports on those risks for those committees. We also look at the board assurance framework and risk register on a monthly basis at our executive management team, which is a shared meeting with Richmond colleagues. We have also undertaken some training amongst our staff so that they understand the principles around risk management. I think it's fair to say there's still improvements that we need to make in the way that we describe some of the actions, but that's steadily improving, and hopefully the training will really come to bear in that. We had an internal audit of risk management recently, and that made various recommendations which we've implemented, and we've also developed a joint risk management policy which is going to our executive management team next week, and will come, if approved, in fact it went last month, it will come to the governing body for information shortly. Has anyone got any questions about the process or any of the risks?
Any questions around the BAF or the risk management? Yes, Sarah.
Can I just, on the QIP one, my understanding is, so in Kingston we have fully identified our required QIP savings. The risk is around the delivery. It's just that that's not how the risk reads. The risk says it's failure to fully identify the required QIP savings, and I think we have identified all of our QIP savings in Kingston. I think our issue is that we need to make sure we can deliver all of that. So I just think the risk is wrong on this one.
Yeah, so sorry, we need to review that. Yeah. Sorry. We'll take that amendment back.
Right, any other comments around the BAF or the risk register? No? Okay, Vicky, thank you very much for that. So if we can come to the commissioning reports, so the IGC report, Fergus.
Thank you, Chair. So this report covers the July and August committees of meetings of the Integrated Governance Committee, and also within the pack, you'll see at the back of the pack is quite a detailed report looking at South West London performance. On the cover note, you'll see that I've summarised just the top 6 constitutional targets and how we compare against other CCGs. So you'll see that for 5 of the 6 standards we are green, as in meeting those standards. I'm pleased to report that for 3 of those we're the top performing locality in South West London. Wanted to just add my congratulations to Kingston Hospital for their outstanding CQC rating. Within the report then I'm just going to tease out some of the particular items that I wanted to draw the governing body's attention to. So in terms of performance, accident and emergency performance, we've identified it in the risk register, we've identified it within the report that it is one of the areas that is still challenging for us. A lot of work has been done over the summer to develop our winter plan for Kingston, Richmond and Surrey Downs, which is how we organise ourselves for our A&E delivery board. I'm pleased to say that we'll be taking that winter plan to the Overview and Scrutiny Committee, Health Overview Panel, and indeed the Health Watch Chairs meeting at Kingston Hospital in December. I'll take it to other partners to share our strategy for coping with what will be, I think everybody's expecting, another difficult winter this year. We're doing well in a number of areas around mental health, improving access to psychological therapies, but a bit of a wicked problem for us in terms of performance, our dementia diagnosis rates. We have, as I've mentioned at previous governing bodies, we have plans to hold a governing body seminar around that particular item. We've done a lot of work, but still not mitigating the challenge of achieving the performance there. We do particularly well around our referral to treatment and our cancer ratings, as Tonya mentioned earlier. Great to see that we've had an outstanding for those. Within the report, there are one or two other items I just wanted to draw your attention to. So healthcare-associated infections in Kingston, similar to other localities in South West London, we're seeing a surge or an increase in the number of Clostridium difficile cases. I'm pleased to say that very, very few of these are reported as lapses in care, but we are working with the Commissioning Support Unit to do a bit of a review of what's happening across Kingston and Richmond and the wider South West London area to look at C. diff rates. I've mentioned already about accident emergency waiting times, but towards the back of the report there are some short notes around the feedback we've had from the various clinical quality review groups over the last couple of months. Whilst noting the good outcome for Kingston Hospital, there are, as I'm sure many people are aware, some challenges at St George's University Hospital Trust. Just want to draw that to the committee's attention. The CQC report has been published for them with a requires improvement rating, and the St George's CQRG will receive an action plan at their September meeting, which in due turn will be received to us as partners. In terms of South West London St George's Mental Health Trust, there have been some challenges around psychiatric intensive care bed capacity, and in the next couple of weeks they are holding the first national Mental Health Trust multi-agency discharge event. We have fed back about how these have been performed in acute trusts, and this is the first time one's been held in a mental health trust, and we're fully engaged in that process to look at things we might be able to do as a system to support discharge, to help access at the front door, so to speak. We've also had the Safeguarding Adults report, which was presented at the committee prior to coming here, and I'm happy to take any questions.
Any comments or questions around the IGC report? So I know quite a few of us attend. No? Okay, thank you very much, Fergus. So if we can come to the finance and quick report. James, do you want to take this?
Keep forgetting. So overall, we remain on target to deliver our year-end control total of £1 million surplus. We are seeing some pressures in the acute area, particularly around Kingston, on some of the non-elective and outpatient areas, which we'll be doing some further work and investigation on. And also, as Sarah mentioned, although we've fully identified our QIP, there remain some risks around delivery of some of those, estimated at the moment about £750,000. So the other final risk just to mention there is there's potentially an issue brewing on, or there is an issue brewing on CAT-M drugs. If members remember last year, there was a pressure through the year, which surfaced at August and then got resolved with through the year end, and we were told not to worry about it in the planning guidance, but there does seem to be a pressure, so we're working with our colleagues across London and with NHSE London to see how we can resolve that. So overall, I think we've got enough in terms of non-recurring mitigations to mean that we're confident we can deliver our target. And QIP planning has now, as always, started for next year as well. So working both individually and with Richmond to move forward on that as soon as we can. Happy to take any questions.
Okay, thank you, James. And do we know what the risk is around the CAT-M?
Funnily enough, I know what the risk is across London. It's 4 or 5 million, I think across.
300,000.
Yeah, but yeah.
Okay, a few hundred thousand.
200 or 300,000, I think it is.
200 or 300,000.
Yeah.
Okay, fine.
Yeah.
Thank you.
But obviously, when you add that up across London, it's a big number.
Sure. Okay. Any comments or questions around the finance report? No? Okay, thanks. Thank you, James. So if we can come to the report from the council members. Atin?
Thank you, Chair. The Council of Members has met once since the last governing body meeting in July. We first welcomed Gina Brockwell, who gave us an overview of the maternity services at Kingston Hospital. She updated us on a number of service updates, for example, the improved MDT endocrine service, which is being led by a midwife, diabetic nurse and diabetic consultant. She updated us on the expanding fetal medicine department. We now have 2 fetal medicine consultants working alongside specialist midwives. Patients now have improved access to antenatal diagnostic testing, free fetal DNA screening for women at high risk. There's also a pregnancy MDT clinic working in liaison with St. George's. There was a number of service updates along these lines. There's been success in improved communication between the maternity services and GPs, especially in light of women being able to self-refer to Kingston Antenatal Clinic, so this to keep GPs within the loop. She updated us on the good overall rating for CQC, but that was from 2016, and as we've heard, there's been an updated inspection since then. Vicky Harvey-Piper, Director of Corporate Affairs and Governance, presented to the members the latest corporate objectives for 18 and 20 that are aligned between Kingston and Richmond LDU that have been agreed by the governing body. The council members were happy to endorse these. Julia Travers, Director of Commissioning, updated the members on plans for developing a local health and care plan for Kingston. Each CCG has been asked to produce this 2-year plan to identify areas where health and care can be improved locally. And finally, Catherine McDermott gave us a update of a primary care update, focusing on the outcome of the primary care at scale workshop that was held in June. And some of the areas highlighted from this were MDT working, IT support, workforce development, and education. Thank you.
Thank you, Atin. Any comments or questions around the council members meeting? No? Okay, Atin, thank you. So as regards the minutes from the previous subcommittees, on finance committee, is there anything else you want to add, David? No? IGC, is there anything else you want to add? Primary Care Commissioning Committee. Jim? Okay, thank you. There's been the reason the policy is approved for information, the EPRR. Is there anything you want to say about that specifically, Fergus? Okay, thank you. So we come to a point in the meeting that we're, are there any questions from members of the public which are pertaining not on items of the agenda? Yes, can you just introduce yourself? Thank you so much for your candidness on this. As regards the waiting lists for assessments, I don't know whether you want to have a discussion, Julia.
I have asked for some more details on this because so that I can come back to you, and because I don't fully understand what the delays are. And so from that point of view, we're in conversation with the service to find out what actually is creating the delays and what is the delay. So I will come back to you, and on your longer question around that service model. So be rest assured, I'm just waiting to pull all that information together.
And how specifically in relation?
So, thank you again for sharing your story. And I also have a role as the mental health lead for South West London. And unfortunately, Phil Moore's not here today, and he's our clinical lead. So I'm sure he would more than happy to meet with you and talk through your experience. I think it is a challenge. I think you absolutely recognise that engaging generally, but also within the mental health services is a challenge, and we're always looking for opportunities to do that. We did a very large piece of engagement work, and I'm going to ask also Iona, because we did this through Thrive Kingston, where we did quite an extensive engagement piece with the local population around their concerns and needs and wants for local services. And that was very much led by Healthwatch. I'm looking at Stephen as well, around getting the views of the population to look at what the population is saying their wants and needs and desires for mental health services locally are. So that Thrive London, which is our mental health strategy that was jointly done with the council and supported by Healthwatch and other partners, really does start to describe our aspirations for mental health services in Kingston. What I would say, it
may not be getting through. I've been part of this service because my daughter's been using it since 2014.
Yeah, so I mean, I say I'll go there. So we have. I mean, we did do quite an extensive piece of work locally around mental health services with the users and carers and people with lived experience. Obviously, sometimes we do miss people, so we need to look at that and where your daughter and you are accessing services. But what I would say, the commissioning intentions is only a snapshot of everything our ambition for mental health in Kingston and South West London. And have you had a copy? Have you seen the Thrive Kingston mental health strategy? So I think we need to obviously share that with you. I think I'll talk to my Healthwatch colleagues. How do we recruit people into the engagement piece? But we do try and use our networks, our known networks, to get the voice. But obviously sometimes we don't get everyone's voice. So obviously you can be on our list now. But I also talk to the trust provider. Does your daughter go to Tolworth or does she go to Tolworth? So we probably need to get down to Tolworth as well. Or are we using the patient group down there extensively? Because the trust also has their own patient group. What I would also we can also put you in contact with the trust patient groups. So they have quite an active patient engagement group that feeds back on their views on services as well. So if the Mental Health Trust was here now, they'd say they have quite a large active patient participation group. So we can also get you in contact with the people that run. Yeah.
There is a real sense of patients being kept at arm's length.
So I think that's also a discussion with the trust directly, which we can facilitate as well. So we can, if you are amenable, we can share your comments with the trust as well, because I think it is about how we do that in co-production. So we as commissioners working with the provider to make sure we have the right service. We can get you the copy of Thrive Kingston, the mental health strategy and our aspiration for mental health services in Kingston, which was built through the patient voice. And we can make sure that you're on our circulation lists. And I'll talk to the hospital around how they are recruiting patients' views, because they have just done a big strategy piece as well for what their view of their aspiration for them as an organisation going forward as well, which they used quite a lot of patient engagement as well.
Okay. I really appreciate you coming today to tell your story, and I've just been reading a few elements here, so I do take it's really quite being very difficult for you at times, and probably not just you, but other families as well. So, as regards the waiting list times, if you, when you do get back to this lady, to Sian, that if you could just circulate that to the governing body members as well, so we're aware about what the difficulties have been. But thank you for this, and we will share it with the relevant population.
How will you get back to me? Have you got an email?
We'll catch you afterwards, okay? So Julie will have a chat with you afterwards.
We have got the email. I think we've got your email address.
Yeah. Okay. All right. So are there any other questions from members of the public? No? Okay, so if I can now close the meeting, noting that the next meeting's on the 6th of November, and that's going to be here again. And if we can just take 5 minutes before coming back for the part 2. Sorry, which is going to be in the other room as usual. Okay, thank you.